CARs came about and have mediated striking remissions in the early clinical experience, and it was really exciting, and that led to FDA approval. And FDA approved tisagenlecleucel, a CD19 targeting CAR T-cell therapy in August 2017. And since then, with commercialization, it's been phenomenal in that there's increased access across many different centers, and more patients can get treated. However, one of the challenges is delivering CARs out of the context of the tightly regulated clinical trials. There's a lot of heterogeneity in clinical practice, and we haven't been sort of standardized in the way that we've been collecting patient data. And so, the consortium came about because we asked the question of how do these CARs function in the real world setting, and what are some of the clinical gaps, and how can we address and improve them? And so, because the individual institutional data is not sort of powered to answer a lot of these questions, we said, okay, let's form collaborations across centers delivering commercial tisagenlecleucel. We established a consortium that to date has about 20 participating sites. And our goal was really to establish and facilitate communication and create a forum for shared data and analysis to interrogate how these CARs are performing in the real world setting, and allow us to ask us some very basic questions and try to answer how we can improve CAR therapy for our patients and patient outcomes. So it was a retrospective study, our first study. It was a retrospective study, and it was geared towards establishing outcomes, both overall survival and event-free survival outcomes in the real-world setting, looking at relapse rates and patterns of antigen expression at relapse, looking at toxicities. And one of our major focuses was to interrogate how baseline features, both patient disease and prior treatment before receiving the CAR, impact outcomes of CAR T-cell therapy. CAR T-cells are a therapy that rely on the patient's individualized T-cell pool. And we know every patient's T-cell pool is different, which means it's really an individualized therapy, which makes it very hard to study. So since commercialization, we have about 200 patients that we've been able to study and question, use univariate and multivariate analyses to question how these baseline features impact outcomes. And one of the really interesting findings that surfaced is that the baseline disease burden really impacts outcomes. So patients who come in with a higher disease burden actually have inferior overall survival and event-free survival at 6 months and a year. And this is interesting because, looking at the prior patient data in clinical trials, it really restricted or defined which patients were treated. And with commercialization, a broader patient sampling can be treated. And this includes patients with high disease burden and patients that were previously excluded from trials with very low disease burden. And these were sort of outcomes that haven't been looked at stratified across disease burden. And so that was one of our interesting initial findings. So currently, we don't really know the ideal disease burden, that patients should have at the start of CAR T-cell therapy. And it's been something that we've grappled with. Data shows different things. So there's data that supports that you need some baseline antigen expression, some baseline CD19 expression to allow the CARs to function. And that's across both physiologic and leukemic B cells. And there's also been data in the adult world and some in the pediatric clinical trial setting that demonstrates that in the leukemia setting, CARs function worse in patients that have high burden. And so we looked at this in the commercial setting and see that really high burden outcomes are quite inferior to those patients who are treated with low burden. For example, in our entire patient cohort at 1 year, the event-free survival is 50%, but in that high burden disease cohort, the event-free survival is only 34%. And so, to us, that begs the question of, should patients be infused with a lower disease burden? And we don't know yet if, debulking will actually improve outcomes, or if high burden is just sort of a surrogate for a worse biology. These are things that we're going to study. But clinically, that may impact what our target disease burden is at the infusion of CAR T-cell therapy. I think one of the really wonderful things is the forging of collaboration. And, along with our initial retrospective study, what we've done is establish multiple working groups to simultaneously ask many questions. Because CAR therapy is still somewhat in its infancy, there are very basic questions that we don't understand. How does transplant affect outcomes? Patients receiving transplants post-CAR, does that improve outcomes or not? What sort of how do high-risk populations perform, such as infant ALL, or patients that have prior CD19 therapy, or patients with high-risk cytogenetics? What does an infection and immune reconstitution look like post-CAR T-cell therapy? What is the fate of patients after they relapse post-CAR T-cell therapy? These are all somewhat basic questions that we don't have answers to. And so what we've done is we've forged working collaborations, working groups to attack some of these specific questions, and those efforts are ongoing. So I look forward to seeing what data comes from that. CARs have been commercialized for about 3 years now, so longitudinal data is really only starting to become available, and it's really a missed opportunity to not look at the prior patient experience that has amassed to date to help us understand how to improve these outcomes. Again, I mentioned that at 1 year, the outcome is only 50%. For patients to be alive and in a relapse-free setting. And we don't have good predictors of outcomes. We can't risk stratify and say, yes, this patient is at high risk of relapse, and this patient is likely to achieve a durable remission. And one of our real aims is to try to understand which patients achieve the durable remission and which patient may be at high risk of relapse and warrant sort of a further consolidative therapy to help enhance the CAR outcomes. And I look forward to seeing what we find and what evolves within the field to help us really achieve more durable outcomes for patients, for pediatric patients receiving CAR therapy.